to the web series today. We have something very special today. That's why I'm just going to take a minute to speak about this. The first thing is that we are taking the next step for IHRS web series in form of starting a grant round from today. And this has been the brainchild of two people I would like to thank. One is Dr. Sanjay Dixit, who's going to be the speaker today, and second is Dr. Anil Saxena, our president. So Sanjay became the moderator for one of the sessions, and he enjoyed it so much that he came up with this idea to have grant rounds as well as mini symposia as a part of IHRS. So between him, Anil, and me, we had a web meeting and we decided to go ahead with it. And he has designed out the excellent program, which subsequently, of course, you will be attending and enjoying the academic treat. Now, that was part of the first thing. Secondly, what I want to say is that from next coming week, we will be having this IHRS web series on Saturday evenings. We had a monkey survey. You all conveyed that most of you want it on Saturday evenings. So for a trial of 4 weeks, we are going to have it on Saturday evening. And in case at the end of the 4 weeks, we feel that, yes, this is a good way to go, we will keep it on Saturday. Otherwise, we'll come back on Friday again. And my entire EC friends are here to support us for that. And they have suggested this idea. Ajay has suggested this idea. Anil has suggested this idea. So we are going ahead with that idea. And from next week, we'll meet on Saturday. That's all I wanted to say. And the moderators for today's sessions are two great friends of mine, Dr. Anil Saxena, our president, and Dr. Balbir Singh, our past president. And of course, Dr. Anil Saxena is the director of EP in Fortis Escorts. Dr. Balbir Singh is the chairman in Max Hospital. So without wasting any time, over to you both, Anil and Balbir, for the session, please.
So thank you, Vanita. It's indeed a pleasure to be here. And I must welcome Sanjay once again as a faculty for today's program. This, as Vanita mentioned, is a new format we are starting today, and we will alternate with mini international symposium and a grand round. So that will consist of 2 lectures, and Sanjay has suggested this format, and we all liked it very much. So Sanjay is very well known to all of us at IHRS. He's a professor at University of Pennsylvania, and he is a director of cardiac EP at the VA Medical Center there. And I've had a long association with Sanjay as we worked together before he left for US. We were together working in the same hospital as resident doctors. Today he will discuss mapping and ablation of outflow tract tachycardias, pulse and pitfalls. I also welcome my co-moderator, Dr. Balbir Singh. He, as Vanita mentioned, he's the chairman of cardiac sciences and of course a very renowned electrophysiologist at Max Super Specialty Saket, New Delhi. He is, as she mentioned, a past president and very dear to all of us. And we look forward to get some real pearls of wisdom from him as well. So I will request Dr. Balbir to say a few words and then start the session.
Thank you, Anil and Vanita, for bringing out such beautiful things in IHRS. And now we were there when we initiated this IHRS. And I thank Sanjay for making it to this forum, and he'll be very useful to all of us, all members of IHRS. And you've chosen a very good topic because this is a problem topic with many of us. Welcome, Sanjay, and I would request you to start your lecture.
Yeah, Sanjay, are you there?
Sanjay, you might have to unmute yourself.
Yeah, Sanjay, you have been muted. Huh? Okay.
Okay.
Great.
Is that better?
Yes, absolutely.
Great. Well, first of all, thank you very much for allowing me to participate in this really excellent initiative that Vanita, Anil have started, and it's really taken on a life of itself in terms of the participation, the topics, and it's just so nice to see the community come together. So congratulations to you, and I'm also excited that we are trying to bring on this new initiative, and hopefully this will allow the international community, not just those with the IHRS affiliation, but otherwise also to appreciate, what we have within India in terms of EP, and then the extended network of people of Indian origin to kind of, interact with our international colleagues. So I can really see this taking off, and I'm excited to participate. For today's talk, first of all, thank you very much for, taking time from your Friday evening to be here and listen to me. I'll try to do justice to the topic and for the time that you have taken to spend here. So, outflow tract tachycardias, this has been a passion of mine for quite some time, and our group also has been associated with this particular arrhythmia in terms of the publications that have come from the program. And I kind of wanted to talk to you a little bit about, how we are where we are in terms of the outcomes that we've achieved with this. And it's been a journey, and we've kind of learned through our mistakes, and we have tried to, present that in a regular way through the different publications. So I hope to kind of share with you the journey that we have taken in trying to deal with this particular arrhythmia. So this is kind of, our 20-year ventricular arrhythmia ablation experience at PENN, and over 5,000 patients between 1999 and 2019 that we have ablated. And while, VT ablation in the setting of structural heart disease tends to get a lot of attention, about 40% of our VT and ventricular arrhythmia ablation volume is in patients with structurally normal hearts, or what we call idiopathic ventricular arrhythmias. And within this relatively large group of 2,500 or so patients that we've ablated in the last 20 years, the majority of these are outflow tract tachycardias. Now, what's interesting about this particular slide, and this was something that I noted a few years back, we keep updating this slide every year, is that if you look at the distribution of idiopathic ventricular arrhythmias between the right and the left ventricle, it looks like the left ventricular idiopathic ventricular arrhythmias are probably just as prevalent, if not more, than the right ventricular arrhythmia. So, when we think about outflow tract tachycardias, generally the RVOT is what we conceptualize as being the most common site of origin, but our own experience at PENN would suggest otherwise. So this is something that I was very interested in kind of assessing, and so this is something that we recently published a few months ago, which was to just look at the trends in successful ablation sites for idiopathic outflow tract ventricular arrhythmia within PENN. And to do that, we looked at a 15-year experience extending from 1999 to 2015, and we divided it into 3 periods. So the early period was 1999 to 2004, the middle period was 2005 to 2010, and then the recent period is 2011 to 2015, which is not as recent, but is still somewhat contemporary. And the goal here was just to see how this particular entity has evolved. And so this is sort of a representation of the year-by-year trends for the distribution of successful ablation sites. And what you will appreciate in these different histograms extending all the way from 1999 to 2015 is that the bars in blue represent right ventricular outflow tract site of origin, or that's where the tachycardia is successfully targeted from. The red represents tachycardia originating from the cusp and the LVOT. And then the yellow bars represent origin from the epicardium or the coronary sinus system. And so just looking at the size of the histograms, there is a clear trend of increase in the volume of outflow tract tachycardias. 1999 versus 2015, there's a significant growth in the volume. And then within the different subgroups, it's apparent that over time, more and more patients that are coming to us for ablation of these tachycardias, the site of origin tends to be in a non-RVOT location. Now, this may be somewhat unique to our practice since we are a tertiary care center and we get a lot of referrals for failed VT ablation. So that may be a possibility, and we'll take a deeper dive into this as we go through the talk. But it is apparent that the RVOT region is not as common a location. And the good news is that despite the increasing complexity of, site of origin of these tachycardias, the distribution, the success rate that we've reported over the 16-year period tends to remain relatively unchanged and quite good. So the overall success of single procedure efficacy for being able to get rid of these tachycardias for us has been somewhere in the ballpark of 86 to 90%. And that has not changed. What has changed, though, is that over this time frame, we are using more and more electroanatomic mapping guidance to target these tachycardias. We've gone on to the irrigated tip catheter platform, and certainly the utilization of eyes, and particularly the Carter sound module, has really enhanced our ability. And I'll show you those examples. And so the rest of the talk here is just kind of, trying to bring you up to speed on what we have done and then how our success rates are where they are in terms of our approach to mapping and ablating these.
So, Sanjay, sorry,
yes.
May I interrupt you in here? There is an icon coming in.
Slideshow module.
Okay.
I think it looks okay now.
Yes, it looks perfect.
Okay. I'm sorry about that.
No, thank you so much for taking care of it.
Yes. So getting back to the outflow tract tachycardias and the common sites of origin. So this is a slide that I borrowed from Sam Asirvatham. And the point of this slide is to kind of just show you the outflow tract region in terms of its extent. So this is a relatively large area if you think about extending all the way from the free wall of the RVOT to the LV ostium, which includes both the aortic and the mitral valve. So this is a relatively large area, almost 6 or 7 centimeters across. But then if you really conceptualize or think about the distribution of the common sites of origin of outflow tract tachycardias, that distribution seems to be in a much more narrower distribution, and that includes the anteroseptal aspect of the superior RVOT and maybe to some extent the adjoining area, but mostly in the septum. The cusp region, which is in very close proximity to the superior RVOT, and I'll share subsequent views with you to kind of make that more apparent. And then, of course, the aortomitral continuity, which is literally just under the aortic valve. And then, of course, the top of the mitral valve and the bordering the great cardiac vein in the epicardium. So relative to the size of the outflow tract region, the common sites of origin of outflow tract tachycardias, their distribution is probably no more than 1 to 2 centimeters in this relatively large area. And so why that distribution is confined to such a narrow zone, I think there's really no clear explanation for that. There are some competing hypotheses, and this is probably one of the more interesting ones, and that is just how the outflow tract region develops. So if you look at the development of the left ventricle versus the outflow tract region, there are two distinct cell lines that kind of lead to the development of either structures. The left ventricle originates from the first heart field, whereas the outflow tract region is derived from the second heart field. So what is it about the second heart field? And so there are some interesting things about these cell lines, and one of them is that the outflow tract remains undifferentiated and slowly conducting until it's incorporated into the RVOT. And even when it's incorporated into the RVOT, it's devoid of certain proteins like the TBX5, which is required for the expression of connexin 40, and it has virtually no connexin 43 expression. So now these two proteins, as you know, are instrumental in cell-to-cell communication. So the lack of the connexin proteins makes that cell line or that cell somewhat isolated from the rest of the ventricular myocardium. And when you have a cell that can function in relative isolation to the rest of the syncytium, what that implies is that that cell can have its resting membrane potential functioning at a different voltage setting. And if the resting membrane potential is at a different voltage setting, the depolarization is different, as is the repolarization. So in some ways, these cells can have some unique electrical properties that could potentially underlie their arrhythmogenic behavior. It's also quite interesting that when you think about, how the cell lines are distributed from the apex to the base of the heart, using faith-based mapping studies where you can actually track the germ line all the way from its early development to adulthood, and this has been done in chicken hearts where the cycling is much faster. What's interesting to note is that the outflow tract region actually has certain cells which have the behavior similar to the cells that exist in the AV canal. So in terms of detrimental conduction properties and things of that nature. So I guess the point I'm trying to make in this slide here is that these cells are somewhat different from the rest of the ventricular myocardium, which may explain their arrhythmogenic potential. But that being said, if you look at what's the average age when patients present with outflow tract tachycardias? If they're presenting in their middle age, then it's hard to invoke a developmental anomaly as the underlying mechanism. If they present early on, perhaps this is more likely. So there may be some other explanation, and that could have something to do with just the fact that the outflow tract region has these valvular structures. So there's interplay of ventricular myocardium with fibrous tissue. And anytime there is ventricular myocardium interacting with fibrous tissue, you can see that there can be islands of cell that can be relatively isolated from the rest of the ventricular myocardium. And that, again, can lead to these unique resting membrane potentials as well as the depolarization, repolarization profiles, which can allow them to become arrhythmogenic. So there is no clear explanation for why this region is arrhythmogenic, but here are just some possible explanations. So getting back to the region itself, so as I showed you in that slide where I outlined the distribution of the arrhythmias relative to the different parts of the outflow tract region, it just shows the proximity of those structures. And typically, I think most of us still use fluoroscopy to at least position our catheters. And when we do that, it's even more apparent just how close these structures are. So here are orthogonal views showing the proximity of two catheters. One is positioned in the cusp region, the left coronary cusp, and the other catheter, it's more clear on the LAO view, is positioned in the anterior septal aspect of the RVOT. And virtually, if you think about these two locations, the catheters are touching each other. So that's how close these two structures are. Same thing when you think about a catheter that's been positioned in this particular instance, the great cardiac vein, and maybe it's dipping into the anterior interventricular vein. And the proximity of that location to the cusp region, again, is pretty apparent here that this is less than a centimeter in this particular set of projections. And then finally, the base of the left ventricle in front of the mitral valve, you can appreciate how that location is in pretty close proximity to the great cardiac vein or the epicardium of the left ventricle. So this may be a little bit more separated than the cusps and the RVOT, but nevertheless, these are fairly close-knit structures. And so it is not a surprise that outflow tract tachycardias share some basic morphologies when it comes to the 12-lead ECG manifestations. And so just by virtue of their location, they tend to have predominantly positive forces in the inferior leads. And then based on, where they are sitting, whether it's the RVOT or the cusp region or the AMC, they can manifest either a left or a right bundle branch block pattern on the precordial leads V1 and V2. And this part of the manifestation of the QRS in leads V1, V2, as well as the precordial transition, is really the first step that I think most of us use in trying to localize the site of origin of the tachycardias. And so what I'm going to try to do over the next couple of slides is to kind of explain to you how the influence of cardiac orientation can impact the unique ECG manifestations of these tachycardias, and in particular, the morphology in lead V1 as well as the precordial transition. So on the top here, what I've tried to create is an electroanatomic representation of the outflow tract region. So the aortic valve is in the center, the pulmonic valve is at the top, and what you'll appreciate from here is that superior RVOT sits a little bit higher than the base of the cusp region. And the cusp region, of course, is also in close proximity and a little bit posterior to the mitral valve. Now, the bottom here is a cartoon where if you're looking down into the outflow tract region, then typically the RVOT, while it's superior as you see here, but in terms of the coronal view, it's a crescent that sits around the aortic valve, such that the anterior aspect of the RVOT is in close proximity to the left coronary cusp and the junction of the left and the right. And then the posterior aspect of the RVOT is in closer proximity to the right cusp. And then this shows you the distribution of how these structures are as you go from the right to the left and from posterior to anterior. So keeping that in mind, the rightward most structure in the outflow tract region is, of course, the free wall of the RVOT. And anything that comes from the RVOT tends to have a left bundle branch block morphology, which is predominantly negative forces in V1. And for the free wall of the RVOT, the transition, the precordial transition, tends to be pretty late, usually at V5 and sometimes even after that. So as you move leftwards from this, the next structure in the outflow tract region is the septal aspect of the RVOT. It has a left bundle branch block morphology, but compared to the free wall, the precordial transition becomes earlier, generally by about V4. Then as we travel leftwards, the next structure in our course would be the right coronary cusp. And again, right coronary cusp relative to interventricular septum is still a rightward structure, which is why it too has a left bundle branch block morphology in lead V1. But compared to the septal aspect, the precordial transition begins to get even earlier, maybe about V3 or V4. And then you move on to the next structure, which is the interventricular septum, which too usually has a left bundle branch block morphology, but the transition becomes even earlier, somewhere around V2 is where you would find this. And then the left coronary cusp, by the time you get to the left coronary cusp, you start to see some positive forces in V1. Oftentimes it can be an RS pattern or it can be a W pattern. And then once you get to the AMC, in the AMC region and beyond, you have predominantly positive forces in V1, which is essentially a right bundle branch block morphology. Although at the AMC, it is not uncommon to find sometimes this very small Q followed by a large R wave. And this QR morphology in lead V1 with inferior forces in the leads 2, 3, and AVF is oftentimes pathognomonic of origin in this AMC region. So that's how lead V1 morphology and the precordial transition can be helpful in trying to get a sense of where the tachycardia might be coming from. Now, the key to the morphology of these tachycardias and the precordial leads is dependent on how those leads are placed. And as I'm sure all of us have experienced, our lab staff can sometimes get the leads wrong. But anytime you're doing a VT ablation, there are patches for cardioversion that have to be placed. If you're using electroanatomic mapping, those things have to be positioned. So it's not uncommon for sometimes precordial leads to be moved around. And so this is a study that we did to kind of assess what malpositioning of ECG leads V1 and V2 can actually do to the QRS morphology of the different tachycardias. So this was a small study, a series of 18 patients, consecutive patients who were undergoing ablation of outflow tract tachycardias. And for each of these cases, what we did is we tried to make recordings of the arrhythmia with the precordial leads V1 and V2 positioned in the standard location, which is the fourth intercostal space on either side of the sternum. And then we made recordings by moving them one intercostal space up and one intercostal space down. So here are two examples. In the first example here is the clinical tachycardia, which was mapped and ablated successfully from the anterior septal RVOT. And so with the leads positioned in the correct position, which is the normal position here, V1 has predominantly negative forces. The transition happens around V3, V4, which is consistent with this location. Now, if you move the leads one intercostal space up, you exaggerate the left bundle branch block morphology and you delay the precordial transition. If you move the precordial leads one intercostal space down, then that tends to attenuate the left bundle branch block. In fact, it causes a little bit more positive force in V1 and it makes the precordial transition earlier. So what are the implications of this? Well, the implications are that if a patient has an RVOT tachycardia and the leads are incorrectly placed one intercostal space below, then you can get an erroneous, predominantly positive force, or if not a positive force, then at least an earlier precordial transition, which would make you suspect that this tachycardia is coming from the left side. Now, the second example is a patient where the tachycardia was targeted from the junction of the left and right cusp, and consistent with this location, and I'll show you an example of this later. Lead 1 is relatively negative, inferiorly directed. There is predominantly negative forces in V1, so still a left bundle branch block morphology, but a very early precordial transition, which is consistent with the cusp location. Now, if in this example, when the leads were moved one intercostal space up, because that tends to exaggerate the negative forces and delays the precordial transition, you can see that this tachycardia, the second panel here, when the leads are positioned one intercostal space up, tends to have exclusively negative forces in V1 and the precordial transition gets delayed. So the point is that if you have a cusp origin tachycardia where you expect this profile, and because of malpositioning, you get the second profile here, you may think that this tachycardia is coming. So that's why it's worthwhile at least spending a few minutes before the case to make sure that the leads are correctly placed. Now, there is another lead that we have found to be helpful in localizing outflow tract tachycardias, particularly in the RVOT, and that is limb lead 1. And in fact, one of the first papers that I published on outflow tract tachycardias was really this particular description of a combination of these, try to localize outflow tract tachycardias in the superior RVOT. And the methodology that we used here, try to show you in this example. So again, you're looking into the RVOT region from the top. So it's a coronal projection. And the way to think about this is the septal aspect of the RVOT. So the cusp area is somewhere here. This is the pre-wall. And then in terms of, the anterior versus posterior, this is the chest, this is the spine. So this is the posterior aspect of the RVOT. This is the anterior aspect of the RVOT. And we use this numbering system, which is sometimes easier for us to, when we're entering information live during the case on Pruka, rather than writing posterior aspect of RVOT, you just say number 1. And so we all understand what we're talking about. So that's why we use this numerical system. You probably have appreciated this Josephson's numbering system for the LV. So it's an extension of the same sort of thought process. But the bottom line here is that number 1 denotes the posterior aspect of the RVOT on the free wall and the septal side. Number 3 denotes anterior aspect of the superior RVOT on the free wall and the septum. And so if you look at 1, so this is base maps that were done on the septal aspect of the superior RVOT. These are base maps that were done on the free wall aspect of the RVOT. And so the point that I'm going to make here is really just if you focus on lead 1, when you base map or when tachycardias originate from the anterior aspect of the RVOT, because this is a relatively leftward anterior structure, lead 1 tends to have negative forces. The posterior aspect of the RVOT, which is a more rightward structure, tachycardias originating from there or base maps from that location tend to have a positive profile. So if you have an RVOT-VT where lead 1 is positive, you suspect it from the posterior RVOT. Lead 1 is negative, it's from the posterior RVOT. Now here is an interesting catch on this as well. So just like you can malposition precordial leads, oftentimes when you're making recordings for the limb leads, it's not uncommon to move those electrodes either from the wrist to the shoulder or sometimes even from the shoulder to the chest. And the reason to move them from the shoulder to the chest oftentimes is if you're trying to do a stress test. And the old literature on outflow tract tachycardias would suggest that exercise and adrenaline tends to bring them out. So it was not an uncommon practice in those days that if somebody presented with outflow tract tachycardias, and oftentimes you couldn't bring them out in the office, then you would have them walk on a treadmill to see if you could get a 12-lead morphology. And so oftentimes when you're doing an exercise stress test to minimize motion artifact, you move the limb leads from the shoulder to the chest. So what can that do? So this was also a series of patients that we looked at to analyze what moving the leads just a centimeter from the deltoacromion location on the shoulder to just the front of the chest could do to the morphology of the QRS complexes in lead 1. So this is typically what we expect would happen. So this is kind of, the orientation of the superior RVOT relative to the axis of lead 1 with the electrodes positioned at the shoulders. Now here is what should happen if you move the lead from the shoulder to the chest. And this may be more apparent in maybe obese people or barrel-chested people, but essentially the axis of lead 1 now moves a little bit further in front of the RVOT. And so the influence of that is in terms of how these forces from the posterior aspect of the RVOT travel relative to this axis. And these are the examples of what that can do. So here is clinical arrhythmia, PVC, that has inferior axis, left frontal block morphology, transition by V3, V4. Suspect that this is in the RVOT, and lead 1 is positive, so this should be in the posterior RVOT with the leads in the standard position. Now when you move those leads from the shoulder to the chest, literally 1 centimeter from the original position for each electrode, see what happens to the morphology in lead 1. It completely reverses. Here's an example of pace mapping from the posterior aspect of the RVOT with the leads in the standard position. As expected, lead 1 in this location has positive forces. And here's an example in the same patient. We're simply moving the lead 1 centimeter from that location to the chest. This is what it does to lead 1. It completely reverses. So in the 16 or so patients that we looked at, there was clear attenuation of the positive forces in lead 1 by moving them from the shoulder to the chest. And oftentimes there was reversal of the QRS axis. So you can see that if you're not paying attention to this, this could mislead you because you would conceptualize based on this morphology that the tachycardia is coming from the anterior RVOT, whereas the actual location of the tachycardia is in the posterior RVOT. So again, these are things just to keep in mind. Obviously, when you're in the RVOT and mapping, your catheter, you'll move around and you'll get to that location eventually, but it may just take a few extra steps versus if up front you're very sure about your ECG lead positioning, then you can be a little bit more certain about which way to go. So now moving on to the next region in the outflow tract, which at least to us has become a very important location in which we have to map and ablate these tachycardias, and that is the aortic cusp region. And again, the point that I'm making over and over again is the proximity of these different structures. So this is a CT segmented anatomy of the cusp region. Again, a coronal projection where you're looking from the head into the outflow tract region. And this is kind of the distribution of the RVOT relative to the cusp region. And so, and then intracardiac ultrasound, of course, makes that very clear, where you can actually see the superior RVOT sitting a little above the cusp region. So the point here is, if you think about the RVOT, and we just went over the posterior aspect of the septal RVOT, the anterior aspect of the RVOT, the numbering system, typically the right coronary cusp is very close to the posterior septal alveoli. And so when you have tachycardias originating from here, they share the properties of superior alveoli. They have a left bundle branch block morphology, but more importantly, lead 1 tends to be pretty positive for the right coronary cusp origin. In contrast, the left coronary cusp is in closer proximity to the anterior septal aspect of the alveoli. And so tachycardias originating from the left cusp tend to have predominantly negative forces in lead 1. There are other discriminating features which can allow us to sort the two out, but there are similarities which we just have to be cognizant of. And then the non-coronary cusp, and I've seen papers that have described ventricular arrhythmias and outflow tract tachycardias originating from the non-coronary cusp. But if you think about just the anatomy and the distribution and the structures that are near the non-coronary cusp, I mean, this is in proximity to the left and the right atrium. And so it's very unlikely that you have a ventricular tissue in this location. Now, sometimes when people were using fluoroscopy to kind of guide themselves, it may be that you could be on the anterior aspect of the non-coronary cusp, and that would be actually the right or the left cusps, and that's how you could get tachycardias originating from them. But otherwise, it seems hard to understand why the depth of the non-coronary cusp can be a source of these arrhythmias. So another location in the cusp region that we described a few years back as being a source of these tachycardias is the junction of the right and the left. This became apparent to us during mapping when we utilized intracardiac ultrasound. That clearly shows, as in this particular instance, the catheter is positioned really at the junction of the two cusps. And tachycardias that originate from this particular location, at least in the series of 15 or so patients that we published, tend to have certain unique features. So if you look at lead 1, V1, it tends to have a predominantly left bundle branch block morphology, but on the downstroke of that, you can see slurring or notching. Sometimes this can have a W pattern. And then when you're mapping in this region, it is not uncommon to find what I'm trying to show you here, which is during sinus rhythm, there is a late potential that tends to reverse itself during the tachycardia. And oftentimes when you think about activation mapping for outflow tract tachycardias, the site of origin precedes the QRS by maybe 20 milliseconds or so. But in this particular instance, it's not uncommon when mapping in the cusp region, you can actually find the site of earliest activation to be as much as 40 or 50 milliseconds before the QRS counting. So that kind of brings us a little bit into what exactly is the source. Is it like these myocardial extensions, just like you have with the pulmonary veins, that can allow this delayed conduction of the source of origin to the QRS morphology? But those are some of the unique manifestations of tachycardias originating from within the cusp region, and particularly the junction of the left and the right cusps. Now, one of the challenges when you're trying to localize outflow tract tachycardias is to distinguish between the cusp and the RVOT. And this is a recurring theme, and many investigators have tried to look at it for obvious reasons, because it certainly changes how you approach the case. I mean, if it's an RVOT tachycardia, it's a relatively straightforward ablation. If it's mapping ablating in the cusp region, it involves a little bit more arterial access, upgrading your sheath, depending on where the tachycardia is originating. And if you're not using ICE guidance, oftentimes you have to shoot the coronary angiogram before you can ablate. So there are challenges, and it'd be good if you could really predict whether the tachycardia is coming from the RVOT or the cusp region. So this is actually a very good paper, and I like it very much for two reasons. One, because the senior author on this, Ed Gerstenfeld, is a really, really good friend. We were co-fellows together. He was an attending at PENN till 2012, and he's now moved to UCSF, where he directs their EP program. But obviously our friendship continues. So I'm very supportive of this effort that he did when he was at PENN. And the other thing is, I think this is actually a really, really excellent paper. It makes a very good point here. And so I'm going to walk you through a couple of examples just to highlight the main findings of this particular study. So here are two patients. Both of them are presenting with left bundle branch block morphology, inferiorly directed PVCs, which are consistent with an origin in the outflow tract region. Now, there are subtle differences between these two examples, which will probably be worthwhile focusing on in order to understand whether this tachycardia is originating from the RVOT or the cusp region. But there are similarities, and so it's difficult to sort this out. And so in this particular paper, there were a series of patients which were looked at to see if there were subtle differences that could help us differentiate between RVOT versus the cusp region. And the way Ed and Brian Batensky, was a fellow with us then, now he practices EP in the Florida region, they looked at these examples and they came up with what they called a V2 transition ratio. And so in the study, what they did is they looked at the QRS complexes during sinus rhythm and the ventricular arrhythmia in lead V2. And then they plotted a ratio. So they plotted the R to S ratio of the ventricular tachycardia and divided it by the R to S ratio of the sinus rhythm QRS transition. And they came up with this transition ratio. And it's a little bit hard to kind of, do this calculation, and I'll explain a simpler way to do this. But the bottom line is that in the 18 patients where the tachycardia was originating from the RVOT region, the mean ratio of the R to S during VT versus R to S during sinus rhythm is about 0.29. Versus for LVOT origin, 18 patients, that ratio was 1.16. When they plotted the receiver operator curves, what they found is that a ratio of 0.6 showed a pretty good sensitivity and specificity for distinguishing the two. So if the ratio was greater than 0.6, then the tachycardia was likely coming from the LVOT or the cusp region. If this ratio was less than 0.6, then tachycardia was likely coming from the RVOT region. Now, to make this simpler, you could make it 0.5, which is more than half or less than half. In doing so, you would certainly lose the specificity of the discrimination. So this is a ratio that is worth calculating in certain situations, not every time. And this is a follow-up paper from, yes, looks like I'm struggling a little bit with my presentation here. Let me see if I can. Okay, don't do that. Okay, good. So again, going back to the ratio that I talked about, and now looking at these examples that I showed you in the beginning again, in this particular instance, that ratio was less than 0.6, it was RVOT. In this second instance, it was more than 0.6, it was LVOT. But here is a more practical way to kind of think about where you might want to apply it. So if you have a left bundle branch block inferiorly directed PVC, and the precordial transition is late, and usually lead V4 is considered late, then you can safely presume it's the RVOT. If the precordial transition is really early, which is at V2 or before, then in all likelihood it is the cusp region. If the transition is very, very late, extending to V5 or even further, then it's maybe further out in the free wall, a non-outflow tract region, and you should be worried about some other entity like the RBC. So the only time that you really need to apply this ratio is if the tachycardia has a transition at V3. So it's a specific group of patients where this can be useful. But again, there are no absolute rules in EP. I'm sure all of us have found this out the hard way. So here is a kind of, one of the things that the paper that Ed put together suggests, that if the transition is at V4 or after, then consider RVOT. So here is a case that I did a few months ago, where if you look at the 12-lead morphology of this, inferiorly directed left bundle branch block transition at V4 or between V4 and V5. So that's by all considerations a late transition. And so using the previous guidelines, you would consider this to be in the RVOT region. And that's where we started. Ultrasound is helpful because you can very quickly create the shell and then just start mapping within the area of interest. And so what you would appreciate in this particular case is that in the RVOT, we found locations that were about 25 milliseconds pre-QRS, which for outflow tract tachycardias is not bad. These are focal arrhythmias, the mechanism is non-reentrant, and so that's kind of what you expect. But what was unexpected is that there's a pretty detailed sampling of the points here, and the early zone seems to be a relatively wide distribution. There is not a discrete red zone that we found here. And so it was the only case, I think, that day, which is another reason I felt, I had the time to map on the left side. And so that's what we did. We went to the right coronary cusp region. And in the right coronary cusp region, we found kind of what I showed you in one of the earlier examples. You see this late potential during sinus rhythm, which reverses itself to tachycardia. And this is significantly early, about 50 milliseconds or so, versus what we found on the right side. And of course, you pace map from there and you get the same sort of delay before the onset of the QRS, which is a pretty good map of the tachycardia. And so this particular location, which was a very discrete point of early activation in the right coronary cusp, was about a centimeter from the early zone in the RVOT region. And so the point of this particular case was that, just because the transition is out to B4 doesn't necessarily mean that it's coming from the RVOT. And a simpler rule that I tend to use is actually look at the precordial transition during sinus rhythm and the precordial transition during the ventricular arrhythmia. And if the ventricular arrhythmia precordial transition is before sinus rhythm precordial transition, then that tachycardia is likely coming from the cusp region. If the sinus rhythm transition is earlier than the PVC transition, then the PVC is likely coming from the RVOT. So that's the rule that I generally use in deciding where to start mapping. Okay. Moving on. So the next area that we have found to be challenging, and I think this is something that many of us share, is this location, which is the LV summit. Now, the MEC Alpine series defines the LV summit region as this location on the base of the LV epicardial aspect. That is a triangular location which is formed by the bifurcation of the left main into the left circumflex and the LAD. The base of the triangle is somewhat imaginary. At the point of the first septal perforator, if you drop a straight line, that becomes the base of the triangle. And then this particular LV summit triangle, if you would, is transected by the great cardiac vein as it becomes the anterior interventricular vein. And in doing so, it divides the triangle into these two locations. And so, just like everybody else, as we were beginning to expand our mapping into the cusp region, we came across these groups of patients that had the classic features of cusp region, but we couldn't find anything really early in the cusp region. And oftentimes it would lead to mapping in the great cardiac vein and the AIV, where we would find some early recordings. And when we didn't really understand the location quite well, it was not uncommon that we would try to go on from the great cardiac vein and still be unsuccessful. And then we would actually go to the epicardium, and in every case you go to the epicardium, but it's a futile effort because the fat pad there is very thick. The trifurcation of major arteries happens in that area. So it was just sort of a frustrating attempt at targeting these. And in doing so, we came to realize that this location, and here's another look at it, this triangular location actually is an area where the ECG morphology can still be helpful in guiding us to where within this location the tachycardias are originating from. And it has some implications for the success of the effort in trying to target them. And so I'm going to walk you through what we have used as a way to classify the LV summit PVCs and what those ECG manifestations have led us to understand about the structure. So one way to think about the LV summit, this triangular location, is that it has a lateral, a mid, and a septal aspect. And the way you can sort that out is, it's a very narrow location, but within that location, if you look at lead V1 and lead V2, you can see that areas or locations on the lateral aspect tend to have predominantly positive forces of a right bundle branch morphology, whereas septal locations, even within the LV summit region, can actually develop predominantly negative forces. Another aspect of this location is posterior basal or anterior septum. And here, just like it was the case for the RDOT, lead 1 can be helpful. So if something is coming from the basal aspect, because there's really no myocardium behind and the axis of lead 1 is somewhere here, all the forces are traveling away from it, it tends to have predominantly negative forces. Whereas a more anterior location here tends to have predominantly positive forces. Now, why is this important? So for us, it was important because in these 19 or 20 patients that we looked at, we found the success of epicardial ablation was very limited. Only about 25% of cases were successful. And the features that were helpful in identifying those cases, and this is sort of the listing of that. So if you look at the Q wave amplitude in leads AVR and AVL, if it's greater than 1.85, which suggests that AVL is more negative, which means the tachycardia is a little bit more lateral, that's a location that's helpful. If the RS ratio is greater than 2, which means predominantly right bundle branch morphology, again suggesting that it's a little bit more lateral, and a lack of initial Q wave in AVL. So these were features which suggested that the tachycardia was coming more from the lateral aspect of the LV summit. The lateral aspect of the LV summit is a little bit away from the trifurcation of the coronary arteries. It's also a location that you can sometimes get to from the great cardiac vein at a relatively safe distance from the LAD. And that was the location that was a place where we were more successful if we had to epicardia. But again, it was only in a minority of patients that we were successful ablating from this location. And it is not a surprise that that can be challenging, because if you think about this LV summit region and you think about the thickness of the myocardium, this is a very thick structure. And while you have surrounding structures that allow you to get to it, if the focus is deep in this myocardium, it's going to be very hard to get to it. And so we have published a series of papers where we have tried to look at features that can be helpful in deciding whether you can be successful from alternative locations like the great cardiac vein or the left coronary cusp. And one of the features that stood out to us was that if you do a detailed mapping in all these locations and none of these entities or sites is more than 5 milliseconds in terms of its earliest activation than each other, then that suggests that the focus is somewhere in the middle and you may be successful from either the great cardiac vein or more likely the cusp region, because the cusp region allows you to deliver higher power. We also found that if you are actually mapping and you find that the site of earliest activation in the great cardiac vein is within 13 millimeters of an alternative location, then you are likely to be successful from that alternative location. And one of the ways that we try to also gauge that is by pacing at different outputs. And so let's say if you are pacing from under the mitral valve on the endocardial aspect of the basal LV, and you know that the tachycardia has its origin earliest in the LV epicardium through a catheter position in the great cardiac vein, but you can't burn there because the left circumflex, or more likely the LAD, is in close proximity. Then if you pace from the LV endocardium and you dial up the output, at a higher output, you get a pace map that mimics the tachycardia closely, and you lose that at a lower output. It suggests that that location has some chance of being successful, but you'll have to deliver a lot of power. Another location that you can consider when targeting tachycardias originating from the LV summit is the superior anterior septal aspect of the alveoli. And so, again, an example, and this is a case actually that my colleague Dave Frankel has published a few years back, of successfully ablating a tachycardia where the earliest site of activation was in the great cardiac vein, but he could not ablate from there because of the proximity to the blood vessels. But this is how close you can get from the superior alveoli to that location. Now, this is something that you can certainly undertake in unique cases where you've tried to do mapping from everywhere else. Word of caution is that when you do that, you are basically ablating very close to the LAD. And we have had actually one case where targeting ventricular arrhythmia sourced from this location did lead to acute occlusion of the LAD. That patient was subsequently stented successfully during the case itself, but that's something you have to be mindful of. So, keeping this in mind, here is an alternative approach that we have used, and this is something that a fellow of mine is actually currently putting together as a series of cases, but an example to kind of make this point. So this is a patient who presented with very frequent PVCs. The PVC morphology actually is right bundle branch block here, predominantly positive in V1, inferiorly directed. So you would expect this to be somewhere around the AMC region or the bordering mitral annulus, but could also be the left coronary cusp. And so that's where, you know, detailed mapping obviously is helpful, and Carter sound generated anatomy allows us to, you know, do this fairly quickly. And what we'll appreciate here is with the detailed sampling of points, the earliest activation seems to be in the base of the left coronary cusp or under it. And so this is another observation that we've made when it comes down to the LV summit PVCs or ventricular arrhythmias from these alternative locations where you find the earliest activation. The typical early activation there is about 20, 30 milliseconds. And the pace maps from these locations are really not that good. So compared to the clinical arrhythmia, pace map from the left cusp and pace map from just under the left cusp, which were the sites of earliest origin, they really are not a very good match. And if you use this proprietary algorithm, which can actually compare and give a percentage of the match, in this particular instance from the site of the earliest activation, just under the cusp region, as you can see with the catheter orientation, the pace map match on CASO is this proprietary software is about 91%. Nevertheless, this was our earliest site. And so using intracardiac ultrasound guidance, you can see the green tip of the catheter, and this is the location. And force sensing allows us to gauge kind of the effort itself. You can see pretty good force sensing here through the duration of this burn. So we gave a series of burns in this location. And what that did is it transformed the tachycardia morphology. So this is something that happens a lot, particularly with the summit PVCs. So here, what happens is the tachycardia transitions from being, you know, right bundle branch block with this morphology in V1, V2 to becoming even more prominent in the notching changes. So subtle variations suggesting that the tachycardia is moving closer to the mitral valve. And so we followed that with additional lesions kind of extending from the true AMC now towards the mitral annulus. And again, using ICE guidance, you can appreciate that the catheter has moved ever so slightly and it's going towards the mitral valve. And so with additional lesions, this is kind of what happened to the tachycardia, where now it has become just exclusively right bundle branch block. The QRS width had widened, suggesting that it's moving further away from the septum. And when we did activation mapping, the site of the earliest activation for this tachycardia was right on top of the mitral valve. So we started burning here, the tachycardia is transitioning over here. And so in this particular instance, we targeted this entire region. Now, mind you, it looks like there are a lot of lesions, and there are, but the zone in which they are distributed is still relatively narrow. So oftentimes, you know, you want to get rid of these tachycardias with a limited number of lesions, but when it comes to summit PVCs, all bets are off. And so finally, after doing all this, we could still get this particular third variation of the original tachycardia, the effort here was to see if we could target all the exit sites, because we felt that the tachycardia was simply just changing its exit and eventually we could just seal it off, but we weren't able to. And so when that happened, we came back to the original site where we had started our ablations. And you can see this area is now completely ablated. This is what the local signal looks like. And so this is the new approach that we are taking, where we get to the site of the earliest activation and we deliver relatively long lesions. So in this particular instance, it took about 25 seconds of energy delivery to suppress it. And then we continued this lesion for a total of 4 minutes. And when we are doing this, this is what you should be able to see on eyes in terms of the increasing echogenicity at the point where a good and effective lesion is being created. And oftentimes it takes up to 4 or 5 minutes for that kind of echogenicity to form. And the reason we are comfortable doing that is because this is where we are ablating. We are ablating from this location to try to get all the way through this myocardial depth. And so that's the experience that we are currently compiling of long duration lesions and the success of that approach from under the AMC region in being successfully able to ablate tachycardias that we think are coming from the Ablation region. Okay, so in the last few slides, just want to kind of share with you some of the other challenges to mapping and ablating outflow tract tachycardias. This is a paper that our group published a few years back, kind of looking at how the orientation of the outflow tract changes with age. And so here is a relatively younger patient where the heart is more vertical, where the outflow tract region is typically on the top of the ventricles. And here is a patient who is relatively older, hypertension, unfolding of the aortic arch, and you can see compared to this, the distribution of the different areas within the cusp region. The right coronary cusp is now relatively lower than the left coronary cusp. And so the point of this particular paper, which was published in 2015, looking at CT and MRI segmented anatomy in patients from different age groups, was that typically when you're in the cusp region, you expect the forces to be predominantly, if not exclusively, positive. And sometimes R wave amplitude is pretty big. But the same location in a younger patient can manifest a very different morphology than an older patient, where sometimes R waves in an older patient can be attenuated. So you just have to keep that in mind. Just because the R waves don't look as prominent doesn't mean that the tachycardia is not coming from the cusp region. Another observation that was reported many, many years back, the first publication I think was in 2003, a series of 3 patients where mapping in the RVOT region suggested that the tachycardia was not earliest there, whereas the profile of the arrhythmia looked like it was from the RVOT, and eventually they were able to identify the site of successful ablation to be above the pulmonic valve. There's another paper that came out a few years after this, a large experience from China and Japan actually. And then this most recent paper by Dr. Feifan Ouyang, who has published in this field quite extensively, was a description of patients where they were able to actually go into the cusp region using a special loop in the pulmonary valve actually, and identify tachycardias and ablate them successfully from above the pulmonic valve. Now, I have to tell you that for all the patients that we have done over the past 20 years, we have never had to ablate above the pulmonary valve. It is quite possible that in our early experience, when we were not using ice, we may have been in that area and we just didn't recognize it. But we have been using ice for the last 15 years or so pretty consistently. And we haven't had the reason to go in that location. So a few things to keep in mind. If you're burning from above the pulmonary valve, you obviously have to be cognizant that septal locations in this area can be very close to the coronary circulation of the left side, including the left vein. So you have to be very mindful of delivering energy there. And then, of course, making a big loop and crossing the pulmonary valve and bending your catheter there to get contact is a good chance you can actually cause damage to the pulmonary valve. All right, so again, just to finish up, outflow tract tachycardias, despite everything that I've shown you and all the challenges that we have encountered, the bottom line is that in the 15-year or so experience that we put together, our overall success of the procedure, despite all the challenges, has been pretty good, about 86%. And this is somewhat underreported only because there are many patients where we didn't ablate because of the proximity of the location to coronary arteries. So if you exclude the patients where ablation was not attempted for that reason, the success rate is closer to 90%. And the good news is that the success rate for us has not changed in the last 15 years or so that we've been doing this. The only difference between those 3 periods is that in the more recent experience, the need for repeat ablation has gone down. And I think that speaks a little bit to using ICE guidance to further increase the accuracy of mapping. And of course, the irrigated tip platform, I think, allows you to create more effective lesions, which is one of the reasons why I feel that despite tackling more complex non-RVOT locations, our success rates have remained good and repeat ablation rates have gone down. And of course, the complication rates for these have thankfully stayed, ballpark about 2%. So for all these reasons, I think, you can make a case that ablation should be considered first-line therapy in the management of these tachycardias. So I know that I've gone a little bit above time, and I apologize for that. Thank you very much for your attention, and of course for spending a Friday evening. I think I'm going to stop there.
Thanks, Sanjay.
Thank you, Sanjay. I think, yeah, Balbir, yeah, please.
Sanjay, for an outstanding lecture. It was really amazing, and I enjoyed it a lot, and so would have all the other members. So we have a lot of questions. I have a couple of questions from my side first. That when you ablate from the AMC, I recently presented a case in the PHRS symposium. We had a LV Summit PVCs, and we were ablating at the AMC, and they would go and then come back. So I increased the power to 50 with the irrigation tip catheter, continued for 2 minutes, and then they didn't come back. So what is your protocol on the settings when you do from AMC and from the AIV? What are the settings on the ablator, and how do you do it? You said that you normally continue for 4 minutes, but what settings do you use for that?
Correct. That's an excellent question, Balbir. Thank you for your comments. So I think what you were describing in your case is not very different from what I was showing, which is basically a long duration lesion, right? So our traditional approach to a standard lesion is 60 seconds. And oftentimes, you extend it by a few more seconds. So the criteria is somewhat arbitrary, but any lesion that you extend for more than 90 seconds, if you look at the profile for how the lesion size increases and where it reaches its maximum heat and convection derived injury, they say that usually by 30 or 45 seconds, that's the half-life of the lesion typically. So by that criteria, 90 seconds or longer would be considered an extended lesion. Now, when we're targeting these arrhythmias, if we see something similar to what I showed in the example where you stay, normally our practice is for any other tachycardia, you stay for about 20 seconds. If you don't see a change, you stop and move on. For these tachycardias, we go on for 60 seconds regardless, because oftentimes you will see late suppression of the tachycardia. And if we see a late suppression of the tachycardia, then we continue that lesion at the very least for 2 minutes, and then we immediately come back on, and then the next lesion could be for 2 minutes, 3 minutes, if we have seen a situation where there's late suppression. Now, when we start ablating, because we use force sensing, typically in this location, if you're coming under the cusp region on the base of LV, as I was doing in this particular case, you can get pretty good forces. It's not hard to get a force of 15 grams or higher, but there is really no limit. You could have a force of 50 grams and you'll be totally fine in that area. So that's the reassuring part there, that it's hard to really hurt anything in that location. And then once you have the catheter position with good contact force sensing, I generally start at 20 watts and I keep increasing the power to get an impedance drop of about 15 or about 10% from the baseline. And I sustain that. And whatever it takes to keep that 15 ohm impedance drop going. Sometimes when the first lesion is being delivered, it's healthy myocardium with good contact. You may not need to go more than 20, 25 watts. But if you burn there several times and you created edema, then sometimes you do have to go up. And I won't hesitate in giving 50 watts. The one thing that we use in all our cases is ice imaging. So if that echogenicity was forming the way I showed you in that example, that's a great sign. That means you're really creating a good lesion. But you also have to be mindful of the bubbles, because if you start seeing a big churning of bubbles, you know you're ready to get a steam pump. So those are the criteria that we use for dialing back or dialing up when burning under the respiration. Now, when we're burning in the great cardiac vein and the AIV, I have to tell you that first and foremost, in those locations, you are limited by the kind of impedance that your catheter will encounter because it's a low flow area. So the first thing you have to do, I'm sure all of us have done this, is that you have to reset the Stocker generator so that it can override the high impedance cutoff. And then in that location, the slow flow, not the standard thermocool, but the SF catheter is a better tool because of the way it cools its tip, which means, it just has that slow ooze. And so it tends to allow you to at least dial up the power. But again, you kind of have to start at about 20 watts and dial it up slowly, sometimes even 15 watts, whatever the impedance there will allow you to. And we have stayed on in that location for up to 60 or 90 seconds. And the impedance drops that you get there are very dramatic. But I have to tell you, the success of ablating from that location, you get lucky when you're able to target it from there, because almost always the coronaries are right there. You're scared to burn there, which is why I think burning from under the aortic valve in the AMC location, I think is a much safer option.
Sanjay, in the AIV, do you use N/2 saline or ice cold saline to increase the virtual electrode or power delivery?
So Anil, this work came from Will Sauer, who was an ex-fellow. He trained with us, and Wendy Zhao, who's also one of our trainees, is now with Will. And they came up with this half normal saline, which is a very interesting concept, but we have never had to use it within our own practice. I'll tell you this, Wendy and I, we were good friends, and she comes back every once in a while, hangs in the lab. One time she was there and I said, Wendy, this was an ischemic BT and I was able to penetrate. And I said, let me try this. So she was actually very, very, insistent that, please monitor with ice, because when you use half normal saline, you really get a lot of steam pumps. And then actually our group, we have an animal lab. So there's a paper that just came out, I would say last month or the month before in JACC EP, where we've reported on the lesion profile with in animal studies of what half normal saline versus normal saline does. And it is a little bit underwhelming. So when you look at these experimental models using half normal saline, actually the lesion size is not that big, it's just a little bit more diffuse. So I'm not sure that you necessarily need to do that. We typically don't do that.
Now, there's another question which basically relates to one of the questions I had in mind is sometimes there is a situation that you cannot induce a arrhythmia in the lab. The patient has frequent symptoms, and when the patient comes to the lab, patient is sedated and there's nothing. And you give isopel or something and nothing happens actually. So what do you do in that situation? There's a question from Ajay Thachil regarding that. Do you do like pace map based ablation or versus activation map based ablation is the question, but this is related to this question. Like, do you sometimes have to use pace mapping alone because you can't induce anything? What do you do in that situation?
Excellent question. I'm glad Ajit was able to join. I really enjoyed his presentation a few weeks ago. He showed some amazing cases. So actually, we just published a paper. I want to say it's in JCE. Rob Schaller, Shaller, is the senior author on that, addressing exactly this. where you use pace mapping in the event of a paucity of PVCs, where you just get maybe one PVC and that's all you have to work with. And then you kind of use pace mapping to kind of guide you in terms of the source. And that experience, thankfully, we don't see those situations too often, would suggest that using pace mapping, and if you use the proprietary software, then with that in mind, the criteria that we use for good pace map is 91 to 95%, excellent pace map above 95%. And mind you, even when you have an excellent pace map, the software is such that if you use humanized look, you may not call it excellent, but 95% plus match is not bad. So that's the criteria that we use if we have to do exclusive pace mapping to target.
Okay.
But that particular experience would suggest that you can get actually a good outcome. Now, before we do pace mapping as a last resort, there are a few things you can do. I mean, traditionally we use isopril. There's actually a paper from Shiv Kumar's group from a few years back, where they actually used beta blockers and atropine to sometimes bring out these tachycardias. So that's another thing to kind of utilize. That it's not always isopril, but sometimes you can have these alternative ways to unmask them. Esmolol drips or a shot of atropine can sometimes bring things out. And then, of course, in our experience, what we found is oftentimes these tachycardias, after we've ablated, if we are testing waiting period, we actually find the washout phase of isoprolol to be the more arrhythmogenic state. So during peak effect of isoprolol, you don't find it, but as it's getting washed out, you start to see these things come through. So I think there's a whole drill of how you can go about. Start with isoprolol, jack it up, let it wash out, wait and see. And if that doesn't do it, try esmolol drip sometimes, which is quickly in, quickly out. Try atropine. So those are some of the other things you could try to do to bring them out.
Do you give any importance to the stim to QRS delay or the latency when you do pace mapping in this situation? And secondly, do you ever use derifilin in this situation to stimulate some ectopy?
So we have not used the second agent. I guess it's theophylline, right? Basically?
Yeah, theophylline, yeah.
Theophylline, yeah. We have not used theophylline, but there are publications that have actually spoken of the value of theophylline. Yes, if you are mapping and you find a stim to QRS sort of latency, that obviously suggests that there is something unusual about that. The most often you find that only in the cusp region, though, or if you are in the great cardiac vein of one of those locations. Generally from the endocardium itself, for focal tachycardias in the absence of any disease, that's very unusual. So we don't specifically look for that. Well, the other thing to keep in mind is that I'm sorry, I just wanted to finish up with one other thought. That if you are having trouble finding the tachycardia, sometimes if you pace map where the tachycardia is coming from or in the vicinity of that, that can sometimes actually cause them to become, you get one beat. After your pacing drive, you may get one beat, or in between your pacing drive, you get a beat. If there's something about pacing from that location that sometimes can be the trigger. Sorry, you were saying something.
Yeah, I was just asking which are the locations on the left side that are best dealt with the transeptal approach? How often do you do that?
Almost never, Anil.
Okay.
Almost never. So
not
I know
for AMC or anything. Okay. All retrograde.
Yeah, all retrograde is our first preference. Now we have had a case or two where there is a mechanical aortic valve, in which we obviously went transeptal to do it, but that was not our first choice.
Okay. And there's another question from Ajit. He is asking again, what do you think is the correlation between the post-RFA clearance of PVCs with the, say, 6 weeks Holter or long-term success? So that's the question.
Yeah, that's a good question. So, in our publications that we have, we use this criteria of 80% suppression as a clinically meaningful endpoint on a follow-up monitor. But it's a little bit hard to kind of be sure. Like, for example, with outflow tract tachycardias, if you have been successful and you've spent the waiting period to kind of, gauge your success, that could be anywhere from 30 to 60 minutes. I think for the most part, that translates into long-term success. The places where we have found a subsequent follow-up monitor to be, to diminish our acute success is one situation is like this, where the tachycardia is in the summit region, you have ablated from another location, and the tachycardia went away. Oftentimes there the waiting period needs to be extended. It's not uncommon that you wait for about an hour and towards the end of it, you do a run of isopull and it can come back. So if you have done something along the lines of what I showed you in this particular example, you can have delayed recurrence of the tachycardia. By the same token, you can also find that you have acute success, but then the patient ends up having the arrhythmia overnight, and then they go.
That happens with all. That happens with any arrhythmia.
2 weeks, and then they're gone. So it's somewhat.
That happens with any arrhythmia from AVNRD to AVRD to anything.
Correct. Right. So then you just have to kind of take your chances on that.
Yeah. So going back to the LV summit, I mean, there are so many approaches. You can go from epicardial, you can go from cusp, you can go from AIV, you can go from LA appendage, and you can go from under AMC as you described so beautifully, looking at the eyes, looking for echogenicity.
Yes.
So there is one question about whether it is safe to use that technique in the absence of eyes. Can we consider burning from under the AMC? It's a very long shot. You produce a lot of damage, and anything over or under will not be good for the patient. It has to be very precise. So, is ice necessary in your view? I would think so.
Well, we have fallen into the trap of ice because we started using it so early on. So it's like a tool that you get used to. That being said, if you are in the AMC region and if you have spent the time to really create the anatomy, so if you're not using ice, then you have to use whatever tools you have to really create the anatomy. So you have to sample adequately to create the mitral valve, you have to sample adequately to define the cusp region. If you've done all those things and you have the electroanatomic map characterized that way, then burning in that location by itself
quite safe.
It can't do much harm, right? The left main is far away and the ventricular muscle is very thick. So no, I think it's fine to do it without ice. You can use impedance drop-offs to guide you, and you really are looking for a 15 plus ohm impedance drop.
What would be the indicator of impending steam pop in that situation?
Yep. Anytime
like you said that there can be bubbles. So without the ice, what would be the indicator for an impending steam pop?
Yeah. So for us, it is if the impedance starts rising. So typically you're expecting the drop and then it levels off. And if it starts rising, actually the lab staff, all the lab staff are taught to just come off or at least bring it immediately to the attending's attention. So that's what we do.
Sanjay, I want to ask. Yeah. So Sanjay, I have an important question to ask. So I will take you to a patient which I did 4 years back. She had PVCs, a 26-year-old lady, PVCs from the left coronary cusp. So we had a left coronary catheter diagnostic positioned, and this was about 5 to 10 millimeters away from the coronaries. It was in a CARTO that case was being done. And the first lesion itself suppressed the PVCs. But since we were doing angiogram, so at the after the lesion, we took a shot, and I realized that there was some stenosis at the bifurcation of the left main, not at the ostium, but at the bifurcation. Yes. And now that stenosis was about 30-40%, and we were very scared. We gave some nitroglycerin, diltiazem. It didn't go even after waiting for half an hour. I'm doing repeated CT angios every year. We did a stress thallium also on that patient, which were all showing that it has not progressed, but remained the same. Yes. Now, this is probably because left coronary cusp is touching that area, which is the LV summit, because we would have created that burn. So how common is it, and how dangerous is it in the long term? She was just 26. So
Yeah, no, I agree. That's obviously a sobering situation, and we all have to be careful, when we do this. So I have to tell you though, there is a paper by Bill Stevenson many years back. We're talking about like 2002, 2003, where he actually, as a case, I think, of LAD stenosis in a similar situation. So it is possible that when you are ablating in the left cusp, and everybody's anatomy is different, and depending on how the left main was traveling down. But the way we do these things, and that's another place where ice is really helpful. So if it's all right with you, I'm just going to go back to that example that I had. I don't know if I can. But I just want to show you this. So this is what we find ice particularly helpful for. So it's not so clear here, but I'll show you another example where it will become even more clear, which is that when you're doing ice mapping and you're creating the cusp anatomy, depending on how you do this, basically from the RV itself, as you clock, you begin to see these different parts, and you keep clocking, and eventually you see the Mercedes sign of the aortic valve. And then if you move your eyes back and forth, you can create pretty much not just the cusp in their base, but all the way in terms of their three-dimensional anatomy. And then the one thing that we always try to do on ice is to define the left main. So we always can identify the ostium of the left main in the left cusp. It's very apparent. And more often than not, you can actually track the course of the left main. So doing that, in the past when we used to burn in the cusp region or map in the cusp region, it was standard practice. We would do the mapping, we would find the source, then the cath lab team would come. We have separate, or you guys are very talented, you can do it all yourself, but the cath guys would come, they would shoot the coronaries. And then the approach I would use is, when they would shoot the coronaries, I would take my catheter and put it at the ostium of the left main, and then the carto rep would take a tag there. And so then I could actually see both in terms of the angiogram, but also on carto imaging, what the separation was. And then soon after, Ed Gerstenfeld moved to UCSF, I think in 2012, 2013, there's a paper from him in Heart Rhythm, where he talks about using ice to identify the left main. And that was kind of what our practice also evolved to. And so since that paper, around that time frame, 2012, 2013, we've actually stopped shooting coronary angiograms. We simply identify the left main on ice. We can track a little bit of the course, and you can almost be sure that the typical sites of origin, even if it's in the junction of the right and the left coronary cusp, it's usually about 1 centimeter or more away from the left main. So that's the reassurance we have now using ice.
Sanjay, it has been an excellent session, super session. And although the time is over, there are a few questions left. So the questions will never end. It's such a fascinating topic, actually. So maybe we can extend the session by another 5 minutes. You can give 1 minute answer to each of these 2-3 questions.
Listen, for all the trouble that you guys have taken to spend your Friday evening, I am all yours. So I'm here for as long as you need me to be.
So one of the questions is, do you ever use cryoablation or use RF energy only?
We always use RF energy. Cryo for outflow tract tachycardias, there's really not much value because, as I showed you in that example, there are alternative locations to get to the LV summit, which means that, even if you're close to the coronaries, you can go from another location. So that would be the only benefit of cryo. The place where we have used cryo is actually papillary muscle ventricular arrhythmias. And actually, our paper was just accepted in JACC EP, so that should be coming out hopefully in the next couple of months. But that's the only place where cryo can sometimes be helpful, because on a mobile structure like the papillary muscles, you're trying to get contact. And so once you freeze, you can be a little bit better with your contact than with an RF catheter. But even in that scenario, we have used it less than 5% of the times. RF is our go-to source.
Any utility of unipolar mapping or unipolar EGMs in this setting?
Yes and no. I mean, one of the benefits of using CARTO is that they actually have a unipolar display together with their bipolar display. So you do get that on the CARTO platform. It's not a dedicated MCL, so it's not the classic unipolar. The one thing you have to be cautious about, especially when you're mapping in the cusp region, because if you have this very small fiber that generates that late potential during sinus rhythm and it reverses during the tachycardia, or a unipolar fall off, that's what you're looking for. You're looking for a QS. You have to have enough myocardium. So when you're mapping in the cusp region and you find the earliest site, you may not get the classic QS because there's not enough myocardium to generate that. So oftentimes you'll get a little bit of a plateau before the fall off. That doesn't mean you're at a bad location.
Another question is, what are the ECG pointers towards a inaccessible or very difficult to access location of VT?
Yeah, so if you have a left bundle branch block morphology inferior axis in relatively early transition, and there is some slurring in the upstroke of the QRS in the inferior leads, that suggests that it's epicardial, but it is not, the classic epicardial on the lateral side. So that could be an LV summit location. Another manifestation of ECG that can sometimes be predictive of an unusual position is this interesting transition ratio. We call it reverse transition. So if you look at leads V1, V2, and V3. So if V1 has a left bundle branch block morphology, V2 has a small R wave, and then V3 has a left bundle branch block morphology. So a little bit more positive forces in V2 compared with V1 and V3. That suggests that it's a little bit more anterior to the aortic valve, and that's a very thick piece of muscle. So that would require a lot of burn. So those are the two things to kind of look for.
And of course, parahesian is a very long subject as such. So any experience, any pearls of wisdom about the parahesian locations?
Well, I stopped my talk.
It will be a long talk again.
Yeah, that's why I stopped my talk.
It's okay.
But here is what I had in mind if I wasn't speaking so much. I actually had a separate session for this.
I can imagine. So we can have a 20-minute session on parahesian and intraseptal,
Yes, whenever you want to. But this is the location.
Any use of bipolar RF ablation?
Again, with bipolar, you can, certainly for the LV summit region, you could try to potentially ablate from the great cardiac vein and the cusp region, or between the great cardiac vein and the RVOT. I just have to be mindful of the LAD being there. The bipolar ablation experience has been currently put on hold. We were participating in a study with Mount Sinai because of some of the complications. So you just have to be, and again, it's not easy when you have two catheters, you're trying to manipulate both of them. So you really need a very good partner with you who can do that.
Okay, great. Do you do any robotic navigation or something like that in LVOT?
We have not. I mean, we have a robotic lab, stereotaxis lab. Yeah. That has actually become our device lab now because nobody uses it.
Okay. So great. I think it's quite late now, and thank you so much. It was an excellent session. Dr. Balbir.
Thank you, Sanjay. It was outstanding and really enjoyed your talk. And we look forward to some more of these talks. And I'm sure Vanita is going to work on that. And thank you very much. The session was very well attended. And if you look at the list of questions, it is unending. So we don't want you to be here the whole day. Thank you so much.
Thank you so much. If it helps and you want to send those questions to me,
we'll do that.
Email. I can try to respond.
So Vanita, you can mail them.
Dr. Sanjay, I will send them to you, of course. I will definitely send them to you. And it was great having you here. It was really great having you here. And thank you for all the help for the grand round and for the mini symposia, which we subsequently will be having. It's been your idea through and through, and it has been an excellent initiation. Thank you so much, Dr. Saxena, Dr. Balbir, for the excellent moderation. And next week, we will see you on Saturday evening, 7 p.m. Indian Standard Time. So see you there, all of you. Thank you so much. In the meanwhile, please log on to the website.
And then just to digress very little here, but maybe Anil and you and I can talk separately, not today, some other time. Just wanted to get some follow-up.
Sure.
Some things that have come up in trying to organize those other talks. So maybe we can just chat.
Definitely. Thank you.
Thank you.
All right, guys. Thank you very much. Enjoy the rest of the weekend.
Thank you so much.
We'll stay in touch. Thanks again.
Great.
Bye.